the colonoscopies really quickly. So essentially, we're gonna have like non-neoplastic are gonna be five polyps, and then we can have like those which are kind of like precancers, and then we can come into those familial syndromes, potentially malignant, and then we can come into polyposis syndromes. So I want to start off this discussion with like hematomas. Hematomas just means some sort of like proliferation, and this is like a part of a syndrome. It could be a part of a familial polyposis syndrome. So this is going to be generally non-neoplastic. So these are solitary lesions that do not solitary lesions do not significantly have a significant risk for transformation. Growth of normal colonic tissue with distorted architecture and associated with Creutzfeldt juvenile polyposis. We can have over here hyperplastic polyps, guys. Hyperplastic polyps, it's going to be a bit most common, and these are going to be small, predominantly located in the rectosigmoid region, occasionally involved to serrated or advanced lesions. So if you have more than 5 hyperplastic polyps, if you have more than 10 hyperplastic polyps, we want to do colonoscopy maybe every less than 10 years. But if you have maybe less than 10, then we want to do colonoscopy. If it's less than 10, we do colonoscopy every 10 years. If it's more than 10, then maybe do colonoscopy every 5 to 7 years. Then we can have inflammatory pseudopolyps, which are going to be mucosal erosions and inflammatory bowel disease. So inflammation that is typically more aggressive, often involves a flat non-polypoid lesion. We can have mucosal polyps. These are usually small, less than 5 millimeters, similar to normal mucosa, clinically insignificant. Then we can have submucosal polyps, which can be leiomyomas, lipomas, neomyomas, fibromas, and other lesions. Let's come into potentially malignant over here. So potentially malignant are going to be adenomatous polyps and serrated polyps. These are non-neoplastic, chromosomal instability pathway of APC, KRAS, tubular, less malignant potential than villus. Tubulovillus has the potential intermittent malignant potential, usually asymptomatic and present with occult bleeding. We can see serrated, these are going to be neoplastic. These are going to be due to some sort of mutation, instability of microstellar lesion, and this is a sawtooth. We can come to FAP, which is familial adenomyosis polyposis, mutation of APC tumor suppressor gene, and this is going to be chromosome number 5. Thousands of polyps arise starting after puberty. Pancolic always involves rectum, prophylactic colectomy, or 100% progresses to CRC. Let's come to Gardner syndrome, FAP, familial adenomyosis polyposis, which is going to be with supernumerary teeth, and it's going to be with some osseous soft bone, soft tissue tumors. So osteoma of the skull, the mandible, congenital hypertrophy of the retinal pigment, and we can see impacted supernumerary teeth, which basically means that normal series of deciduous and permanent dentation. We can see Turcot is familial adenomyosis polyposis, or Lynch syndrome, a plus malignant CNS tumor, so medulloblastoma, glioma, Turcot over here. And we can see Peutz-Jeghers is going to be autosomal dominant hematomatous polyps, which are going to be essentially these are going to be more like hyperpigmented macules on the mouth, the lips, the palms, and the genitalia. Increased risk of breast, GI, colorectal, small bowel, pancreatic cancer. Juvenile polyposis syndrome is going to be autosomal dominant syndrome in children, so typically less than 5 years, and there's going to be featuring numerous hematomas, polyps in the colon, stomach, small bowel, increases of colorectal cancer. We can see Lynch syndrome is going to be the formerly called the hereditary non-polyposis colorectal cancer, autosomal dominant mutation of the mismatch repair, and this is going to be MLH1, MSH2, and there's going to be microstellate instability and 80% progression to colorectal carcinoma, proximal colon is oxygen involved, and there's going to be endometrial and skin cancers. Then we can see colon screening. If you have a FDR under the age of 60, you want to screen them at either 40 or 10 years before the diagnosis of that relative. So, if, for example, if he was born, the relative was at 56, then we get that 10 years before it's 46, we screen at 40. But if the relative is at 49, then 10 years before that's 39, so we're going to start at 39, which is less than 40. We repeat every 3 to 5 years. IBD such as Crohn's, ulcerative colitis, we wanted to start 8 years post diagnosis, and then colonoscopy biopsies every 1-2 years. So the question can be over here: a 37-year-old male comes, a 32-year-old male comes. He has had IBD for the last He was just dying IBD. When we do colonoscopy, do we do it at 45 or 40? The correct answer is 40 because 8 plus 32 equals to 40. And then familial adenomatous polyps at 10 years, and Lynch syndrome we start at 20 to 10 years, repeat every year. I just want to come in, guys, and recap this over here. We're going to have the hyperplastic polyp, which is the most common polyps. Hematoma just means destroyed territory. Either inflammatory polyps or pseudopolyps. Mucosal are going to be less than 5. Pseudo, we can have some mucosal some mucosal, which are going to be lipoma, leiomyoma, fibroma. And then we can have over here adenomatous polyps, which are going to be basically neoplastic. Serrated can also be there. Then we can have familial adenomatous polyposis, which is also going to be a syndrome where there's a thousands amount of polyps. Gardner syndrome is going to be polyps plus you're going to get supernumerary teeth. You're going to get hypertrophy of the retina, plus you're going to get osseous soft bone mandible lesions, tumors. Turcot is going to be a FAP with, it's going to be basically FAP with or Lynch syndrome with your medulloblastoma. And then we get Peutz-Jeghers, autosomal dominant hematomatous polyps, which are going to be involving your palms, your soles, your genitalia, your lips, your face, mouth and lips. And we can have more other tumors such as GI, breast, pancreatic, small bowel, stomach. Juvenile polyposis is going to be in children less than 5, so this is going to be hematomatous polyps in the colon, small bowel, and this is going to increase risk of colorectal cancer. Lynch syndrome, guys, is going to be here. This is going to be hereditary non-polyposis colorectal cancer, autosomal dominant mismatch mutation of MLH1, MSH2, microstrain instability, proximal colon opposite involved, and this is CEOs, colorectal, endometrial, ovarian, skin tumors. If your first degree relative less than the age of 60, you want to do at 40 or 10 years before his diagnosis. Repeat every 3 to 5 years. Inflammatory bowel disease, you're going to do it 8 years after diagnosis and repeat 1 to 2 years. FAP, it starts at 10, repeat every year. The other one, which is going to be Lynch syndrome, start at 20, repeat every 1 to 2 years.